Good morning, Ewa.
Good evening from here.
Well,
To my
it's a nice surprise. We start in 30 minutes, okay?
30 minutes, so please, I want to hear and maybe give some
Okay.
comments.
Okay, 30 minutes.
Because
okay?
I have been working also in the developing countries,
Yeah, as you know,
rich countries.
yeah, you know it's different.
Have experience of both types, developing countries and
Yeah, this is going to be a good discussion for you, just the difference between treatment in different countries.
yeah, it is.
Okay, I'll see you in a half hour.
Okay, thank you, John.
Okay,
Thank
sure.
you. Yes.
Okay.
I will join a meeting in half an hour.
Very good.
There is a discussion about neurosurgery in developing countries and rich countries. So
Okay.
this is interesting.
Okay, very good.
This is the link. If you are interested in. What is that?
Yeah, I will see just because I have Wi-Fi now. Because for Zoom and it's suck a data you have.
Good morning, Juan.
Morning, how are you?
Good, how you doing?
Good, good. It's good to see you, John.
Yeah, it's great to see you.
Hmm.
You're gonna get comfortable with this platform.
Yes.
You still awake? Yuha's here.
Oh wow, it's an honor.
Yeah, I think he's taking a little nap. Are you there, Yuha? Okay, we'll leave him alone. Okay, yeah, you're familiar with the platform.
Yeah.
I'm
really,
there.
right?
I'm
Screen share and everything else. You've done it before.
I'm here.
Yeah, I think he's got a really good idea to do this.
Mhm.
And I appreciate you taking the time. And it was hard for us to
It's
get
my
someone.
pleasure. It's my pleasure always to be with you in the webinars. You have done so much for neurosurgery.
Thank
So
you.
it is something very special.
Well, I think Juan's going to be a big part of this. He seems to like the tech. He's a practicing surgeon in Tampa, Florida. Mostly spine, right, Juan?
Yes, sir. Yes, yes. But I
So you are,
yes, mostly spine, but I do also neurosurgical oncology.
When you start, you're
but
going to do it all, right?
Yeah, well, actually, I did 2 fellowships. I did one in spine and one in brain tumor.
Oh, okay. At Tampa?
No, I did at Emory.
Oh, okay. Atlanta.
Yeah.
Okay, we start in about 12 minutes.
Oh,
I'll be-
doctor, how long do you have this webinar to be lasting for, roughly?
we've done them for a couple of years, about 3 or 4 years. But of course, it changed totally with the pandemic.
Mhm.
We used a platform before called Google Hangout. It was a
Yeah.
little more, are you familiar with that? Were you into doing that at all?
Mm-hmm.
Oh,
Yes.
okay. So you're different. Most people didn't really try Google Hangout. It was a little harder than Zoom.
Mm-hmm.
And it was hard for me to convince neurosurgeons to try it. Now I don't have to convince them because they know Zoom.
Gotcha. And what's the length of the webinar today?
This particular one is about, well, it's flexible. We can go as long as you guys go, there's no limit. But generally they last about an hour, generally.
Perfect.
So I guess you talked with Sarath about what you guys want to do, right?
Yes, he told me he's going to show some of his cases,
Okay.
how he handled it there, and I'll give him some ideas and sort of compare what we would do here in
Great.
general terms,
Great.
to point out the differences, the challenges, and maybe show some films that I have to do some contrast.
Yeah, it sounds like a really good premise to me. And when he told me that, so, well, we've been trying to arrange it for a while now. But anyways, we start in 10 minutes.
Thank you.
I'll be back.
Mhm.
All right, Sarath, are you there?
Hello. Hi, John.
I can't see you. Where are you at? Are you there, Sarath?
Yeah, I'm there. Can you see me?
Oh, there you go. You met Juan before, right?
No. We
Oh, you
haven't
just-
before.
Oh, you've just been texting.
Yes,
Hello, Suras. How are you? It's an honor to meet you.
I am good. How are you? How are you, Juan? Same here. It's a privilege to connect with you today.
Likewise. Thank you.
Am I pronouncing your name correctly? Is it Juan?
Yeah. Yes.
Okay,
Thank you.
great.
Yeah, I'm sure you know Victor Hugo Perez. He has two names, Perez also.
Yeah, just like I am.
Well, it took me a while to get used to. I lived in Mexico for a couple of years. The two names that people have, the maiden name, you know how it is.
Hmm.
That was a little different for me. Change my background. We start. Okay, I invited a neurosurgeon from India. He worked with Charlie Teo in Australia, I guess is a big endoscopist. He's going to be here in a few minutes. Because I'd like to have a neurosurgeon moderator if possible. Because once you guys get into discussions, yeah, you know, it's better that you have a neurosurgeon kind of moderate running the show.
Perfect.
Yeah, there's a lot of, like, Zoom is getting more advanced in America anyways. It's getting, universities are starting to use it and learning how to you know, market them.
Don't worry, don't worry.
I think you may want to mute the others.
Yeah,
attendees.
that's a constant battle. It's not a battle, but yeah, that's part of my job is to mute people that forget they're not muted. We start in 3 minutes. Yeah, that happened with some big conferences with Michael Lawton. Because during the webcast, I put the link on different social media during the broadcast. That's a good time to spread the word. You know, when people are at the internet, they said, "Oh, check this out." So. Where is Ashish?
Hey, Suraj.
Yeah.
Hey, what city are you located at? What city are you located at?
Yeah, I'm at Ratnapura. I'm from Colombo, but I'm working at Ratnapura, which is the Sabaragamba province.
Okay. Very good. Very good.
You're from Tampa, is it Florida?
Yes, that's where I live and work. Yes. Yeah. But I'm originally from Peru. Originally, I was born in Peru. Yeah, but I did my residency, fellowship, and faculty position here.
Okay. Are you specializing in spine or you do cranial as well?
I did a fellowship in complex and reconstructive spine surgery at the University of Michigan. And then I did another fellowship in neurosurgical oncology at Emory. But I do probably 75% spine, complex spine. Yeah.
Okay, great.
Okay, let's start. Ashish is a little late. I'm going to take his job over. Okay, you guys ready?
Yes, sir.
Okay. Let me introduce you first. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from Miami Beach in the background here. It's just like it is. We have a wonderful broadcast today arranged by Sarath Munasinghe, a neurosurgeon from Sri Lanka who came to me with the concept. He says, John, let's compare the systems. Let's compare the third world, the way we treat certain problems in the third world compared to the first world. And Juan Valdivia, a neurosurgeon from Tampa, agreed, thankfully. So we'll start the broadcast, and let me introduce Sarath first. And Sarath, just kind of explain what you want to do, and introduce yourself and explain what you want to do, etc. And welcome.
Thank you, John. Hi, everyone. Good morning, and good morning or good afternoon, good evening, wherever you are. So welcome to the Neurosurgical TV, and I'm delighted to start a new chapter, a novel chapter in Neurosurgical TV. So we had this idea of comparing the systems, the approaches, how with a given case scenario, how a neurosurgeon in a third world country with poor resources like us would have handled this, and at the same time how a neurosurgeon from affluent or a resourced, well-resourced environment would have handled the case at the same time. So we tried hard, and today I think it has become fruitful. So let's make this concept a fruitful one. So first of all, I'm very thankful to Juan Valdivia from USA for agreeing to start the proceedings. So this is going to be the first chapter. So we plan to go ahead with more and more cases in the future, depending on how it goes. So we have selected few cases today, mainly on the cervical spine. And so we will be discussing few cases of mine. So how I have approached, what went wrong, and what are the complications, what would have done better, with the expert opinion of Joanne. So he will be talking with his experience as well, and with his cases. So we can learn and make it a good learning experience and a novel experience to all of us. So shall I start the presentation with the screen sharing, Joe?
Sure, however you want to work it.
Right, okay. So I will start the screen sharing. Can you see my screen, John?
Not yet, not yet.
Not yet?
No, not yet.
1 second.
Okay.
Can you see it now?
Yes, yes.
Okay.
You
Good.
want to make it bigger? You want to make it, there you go, perfect, perfect.
Great, okay. Right, so let's start. So, as you know, so I am from Sri Lanka, and which is a third world country, and I'm from an area which is called Ratnapura, the only neurosurgical center in Sabaragamuwa province, which drains a population of more than 2 million. But it's a relatively new, I mean, you can't say it's new, it's more than 2.5 years where the neurosurgical unit was established, but the facilities, the infrastructure is not very great still. So we have this daily struggle, so many drawbacks, so many difficulties. So let's see the deprived, whether we can get to this level at least in few more years. So deprived, affluent, right, okay. So this is the first chapter. So as I said, we'll discuss the cervical spine. And let me enlighten you about the objective, since this is the first time we introduce this concept. It's mainly educational, not to depreciate or not to under-evaluate or underrate any type of system. So we know that, as I said, this is mainly how we utilize the minimally available resources at its maximum. And we know about evidence-based medicine, and some would argue principles are principles. I mean, wherever you are, that's true. Principles are the same. But when it comes to, I mean, the practical situation, even though we have the knowledge, the application is not always feasible. Applying it practically is difficult due to the available resources. So that's what I'm going to tell you, the practical obstacles in low-resourced environment we encounter every day. So we want to find out the solutions, and we have identified the alternatives. So let's see how it works in my practice, and we'll compare it with John's practice as well. So this is principles of my practice. I think if I don't share this, it's not complete. So the principles, I think I showed this slide to you as during my previous presentation on spine case review as well, because we don't have we don't have so many imaging modalities as we like. So we have to mainly depend on our clinical acumen and clinical examination. For example, a patient with spine injury, we had to, a bigger percentage, we had to depend on our clinical acumen. And we must know the treatment options available. That is a must. You should have an insight of what is available for you. And you should know the evidence. You should know the literature. That is your homework. So out of that, depending on that, you have to identify the best practical option which suits and fits into your system and the patient, my system and the patient. That is the most important thing. And that may not be ideal sometimes, but that's how it goes. That's how it works. And always we have to identify the benefits versus risks. If it is going to risk the patient's life, we should not embark on that. And at the same time, I had to keep in my mind, can I manage the anticipated complications in my practice? So that is very, very important. So if there is a complication, can you manage it without sending the patient to a different to a different center or your colleague? So that's the importance of having an insight of your capability. You should be confident, but not overconfident. And you should never try to be heroic when you work in such circumstances, under such circumstances. And at last, but not least, is the procedure really necessary and indicated? Because I have seen so many patients in my practice, especially for the spine cases, that patients were operated without absolute indication, unnecessarily, with inappropriate methods, right? So these are the challenges faced every day. For me, this is my practice, this is for me. So this is just to show you that, that to convince you that I'm the ideal candidate to take on the discussion. So the first thing, I don't have no emergency theater facilities and lack of theater time. So I don't have an emergency theater. I may be the only neurosurgeon without an emergency theater in the whole country. That is mainly because lack of anesthesia cover, no adequate medical officers of anesthesia. So there is nothing called emergency theater for me. So I'm having 3 days of theater from 8 a.m. to 2 p.m., Tuesday to Thursday, that's it. So all these surgeries being done during that time. And so I think so the first sentence, the inability, shows how much disability is there. And the rest is substantial. Lack of proper imaging modalities, no MRI, recently got an MRI a few months back. Before that, no MRI available. CT, 16 sliced. Patient comes with subarachnoid hemorrhage. You do the CT angiogram, most of the time 90% negative. Sent to another center, sent to private sector, it becomes positive. Okay, lack of ICU HDU facilities. Even before the COVID hits the country, only 5 beds for the ICU I had. So I had this everlasting problem. But now, after the COVID pandemic, all the ICUs converted to COVID ICUs. So it's very difficult to find out an ICU bed. So the patients, patients with tumor, so say biphasic dislocation with problems, with respiratory problems. They have been operated for hours, then been sent to the wards, then they develop aspiration, post-op chest infections, even to the ICU, they develop ventilator-associated pneumonia. Right. And then lack of these essential instruments, accessories, consumables. You don't have pedicle screws, don't have lateral mass screws, don't have ACDF cages. The list is exhaustive. I can tell you as the discussion is going on. So we had problems with post-op care management. We don't have trained staff, problems with rehabilitation, not adequate physiotherapy, limited bed capacity. As I said, 2 million population, the single neurosurgical unit for the whole province doesn't have a separate ward for the neurosurgical unit. So the neurosurgical unit is located in neurology ward. It's just a part of the neurology ward where we have 5 beds for the male patients for the whole province, 3 beds for the female patients. For the whole province, we have 3 neurosurgical beds. So you can imagine, right? So poor resource quality, C-arm, CT, etc. I'll show you lack of manpower. Just 1 medical officer. For the whole unit, I'm having just medical officer to assist me and 2 released house officers. Released means soon after the internship, they have no experience at all, but they do a tremendous job. So with only this lack of manpower, we are managing and we have done this amount of work. I'll show you later. So comes to the discussion. So that was the introduction. So I think you understand what we are going to do. And so let's get on to the discussion. So today we are mainly focusing on the biphasic dislocation, cervical biphasic, because it's a controversial area. And I hope no guidelines. So proper guidelines not there yet. So these are the controversies. So this is going to be an interactive session with Joanne. So the place of close reduction, we know it is a bit controversial. So whether to reduce first or go for MRI first. So this is the controversial area. So this is my view on this controversy. So first of all, I would like to go ahead with this, and I would like to have Juan's opinion on this. So I believe in a complete, if the patient is having complete injury in biphasic dislocation, I think in my practice, I usually go for urgent close reduction before MRI because of 2 reasons. Because close reduction is not a difficult task, and we have the facility to do that. And getting an MRI done, especially at night, is not, most of the time is not possible. So I would go for urgent close reduction. If it is successful, I would go for MRI and then decide on the approach. If not, whether to go for urgent open reduction anteriorly or to go for MRI and determine approach, which is a gray area. So I would like to ask Joanne his opinion on this concept. Would you agree with me, or you have different opinion, Joanne?
Hello, Shrath.
Yes.
First of all, thank you very much for allowing me to discuss with you. It's an honor. I think you're practicing for what you're saying and with some difficulties in logistics, and I think you're doing the best you can do with your resources available, right? Your available resources. In bilateral dislocated facet or jump facets, my practice has been to do first, well, in here, a CT scan usually is done in the ER, which is the sort of like the gold standard for trauma workup. And then we usually request an MRI as soon as possible. And the reason why is we would like to know, depending on the patient's age, if there is just the pathologist or the culprit is only the jump facet or dislocation, or that plus severe stenosis or an epidural hematoma. So I'd like to rule out issues that will be compressing the cord before I do any close reduction. However, I have to confess, I haven't done many close reductions. I've seen mostly open reductions. as my practice. So.
All right, great. And I think the more complicated or the more controversial aspect when it comes to the incomplete injury. So as I said, in my practice, because of the circumstances, I usually go for urgent close reduction if patient has no contraindications and the patient is stable. So if successful, we go for MRI and surgery. If failed, then again a gray zone, whether to go for MRI and determine approach or to go for an urgent open reduction anteriorly. But anyway, if I don't have MRI, I usually approach anteriorly to remove the disc and then posterior. So this is close reduction. We have this Gardner stance. So we know 80% of dislocations can be reduced and 1% of permanent risk of permanent neurological damage with traction and 2 to 3% of transient injury. So this is the fear of herniated disc, as we all know, exclusion of intervertebral disc with this case report. So, but I agree, I hope you agree with me that the chance of permanent deterioration or transient deterioration is less, is it? You agree with me, isn't it? Right. Okay, so this is the AO guidelines, for the approach to determine the surgical pathway, and I follow this. So reduction successful if there is a disc herniation, bilateral, I usually go anterior and then posterior. Same unsuccessful reduction, disc herniation, bilateral, yeah, discectomy, reduction, fusion, and then posterior fusion. So advantages of anterior approach, we all know this: less muscle trauma, load sharing, disc removal. Posterior approach, the control is better, the 3D control is better. So we can easily manipulate because of the fixation, faster drilling possible, and especially helpful at certain levels like C6, C7 junction. And when you compare the complications, posterior approach, they say more pain long-term. And when you compare the reduction rates, it's almost the same between anterior and posterior, not much difference. Delayed instability, same, not much difference. Delayed kyphotic deformity, slightly high in posterior group. Graft failure, high in the anterior group. Mortality, slightly high in the anterior group. And not significant difference according to the literature. Right. So let's get into the first case. That was the introduction. So this is my case number 1, 37 years old male, attacked by a bull from the back on 10th of August. She presented around 10 p.m. And as you said, as Joanne correctly mentioned, we do the X-rays and CT. CT is the standard. So the CT showed bilateral facet dislocation. I hope you can see that and you agree with me. Right. Okay. And patient was in spinal shock and he was unstable. Asia A. This is aorta C, right? So patient presented at 10 p.m. and patient was unstable, started on inotropes, and cannot be, it's not possible to transfer him to a theater. Or else I could have done the close reduction because it's not a big thing, doesn't need anesthesia. But as I said, I don't have anesthetic cover at night. So I did not want to bring this patient to the theater because he was unstable. So I planned immediate surgery next day morning with an MRI. So this is the MRI. You can see the disc, I suppose. Yeah, you can see clearly here. There's a disc. It was a large disc. And the axials, you can see the disc there. Right. So I would like to discuss with you a few methods of reduction. So out of these, suppose in this patient, what would be your choice of reduction method here, Joanne? And how do you approach this case?
Mm-hmm. Would you mind going back to the sagittal T2 MRI, please?
Sure.
Wow. Take a look at this.
Yeah.
Yeah, and you
There
said
is-
he was, yeah. You said he was
yeah.
hypotensive, right?
He was hypertensive in neurogenic shock. There is cord edema starting from C3 all the way down to C7. And I don't have the stir. Yeah, I can remember the stir showed features of posterior ligament disruption as well.
Mm-hmm. Right. So it looks like you have. Let me see it one more time. What level is that? 4, 5?
5-6.
5, 6. Well, in neurogenic shock, it's I think in this case, the young patient after trauma, it will be very difficult to take him to the operating room, because the risk of an intraoperative complication like hypotension or intractable shock is not small. So I think I'm seeing your point. This is a high risk for perioperative complication if you take this patient to the operating room. I see the point of doing a close reduction in this case. If this patient will be hemodynamically stable with an incomplete spinal cord injury, and with no major hemodynamic concerns for anesthesia, I would opt for emergency anterior approach with reduction. What I do usually in any ACDF, particularly in this case, I'll use Casper pins, and then we use a trial, like a 6 or 7 millimeter trial. So and I'll show you a video if you'd like later. As I expand the carpal, as I distract the Casper pins, I use the trial to sort of use leverage to open the space, and at the same time distract the Casper pins. And I've seen quite a bit of high restoration in these cases. So I will try that first. And then definitely anterior and posterior approach, given the compromise of both columns. Yeah, that's what I'll do.
Great. 100% agree with you. So these are the options with traction. So traction was out here for me. Traction under anesthesia. Usually I don't do this. Intersegmental distraction, flexion with Casper, leverage within the facet joint. Sometimes you need to remove the superior facet or remove distract posteriorly. So this is the method I use, because I only have the cob in my armamentarium. Which is more suited for this procedure, because the Casper pins I'm having, one is not properly fitting, so it's difficult for me to use the Casper pins for the reduction. So first, as I said, we approached anteriorly, but unfortunately I could not reduce the fracture anteriorly. It failed. So what I did, I removed the disc, big disc, and there was so much compression of the spinal cord. And the next thing I wanted to do, so I wanted to put a buttress plate, but I didn't have a buttress plate. So my concern is, so anterior fixation failed, so I had to go posteriorly and then come back anteriorly and do it. So it's 3 times I had to turn the patient. But in my mind, I had this feeling that this patient would need a tracheostomy. And unfortunately, I had few bad experiences during that time, that most of our tracheostomies were getting infected. So I had this doubt. So if I'm going to do a tracheostomy in this patient, so putting an allograft, putting a cage to this, the C5, C6, the disc level, would cause him problems if we are going to do a tracheostomy. So what I was thinking, putting a cortical fibular bone graft to the defect, and then do plating, anterior cervical plating later. So, but since considering the patient's instability, I didn't want to put a fibular graft from the periphery, which makes the procedure too lengthy. So I removed the disc, turned him to the posterior aspect, reduced the dislocation, and fixed him. I had to fix him from C3 to T1. That is because of the posterior ligament disruption. And he had significant posterior ligament disruption with facet fracture on the right side at C5, C6 level. And I had to do the decompression as well because the cord was under so much tension because of the edema. So this is what I did. T1 level, crossing the, because edema was from C3 to C7 level all the way down, C4 to C7. So I had to include the junction as well. So pedicle screws to T1 and all the way from C3. But I could not cannulate these region because of the facet fracture and poor bone quality there. So you can see the alignment is good, C5, C6. And since I have fixed him, I fixed him posteriorly, then I wanted to do the fixation anteriorly later, within a few days or within 1 week's time, once the patient is stable. Do you have any comment, Joanne? What do you think?
I think this is a possible occurrence. Like you go and you do an anterior approach and you're unable to do the proper reduction. I think you took the right decision by taking the mass effect, the ventral mass effect, away from the ventral thecal sac. I think that was definitely the right choice, and then go posterior as a plan B. Yeah, I think I would have done the same if I would have found a difficulty reducing from the front, and I'll just go take the mass effect and then go posteriorly.
Okay, thank you. So this is the pre-op CT and this is the post-op CT.
Mm-hmm.
Okay. Any comments? Okay.
Well, that's good.
So, right, thank you. So this is the axial. And as I said, so this is post-op day 3. Patient was sent to the ICU, and this is post-op day 7. So you can see his whole lung is gone on the left side. So no wonder that was my assumption. So this is not very rare occurrence in our setup. So patient developing ventilator-associated pneumonia, they aspirate. Wow. And so we had to go for a tracheostomy in this patient, as I said, because we don't have ICU beds. There are 70 consultants in my hospital, and only we have 5 ICU beds. So you can imagine the importance of an ICU bed. So we had to do the tracheostomy, and we had to send the patient to a peripheral or the base hospital in few days' time for the rehabilitation. So this is after 2 weeks' time. So my respiratory physician did a wonderful job. He did the bronchoscopy. So this is after 2 weeks. And this is him. This is after 1 month. So the prognosis was not very good. So according to what I have seen, his upper limb power improved a little bit, but lower limb power was 0. This is after 1 month. And yeah, so he's still at home. He's at home and he's still on a tracheostomy tube, changed to an uncuffed one. So this is 3 days back. His brother called me and I asked him to send a video. So you can see there is not much difference in the muscle power. It's the same, and the lower limb power is still 0. So according to what I have seen, I think the prognosis is not that good. So I would like to ask to share your experience, Joanne. So what do you think about the airway management in these patients with bifacet injury according to your experience? How often that you needed a tracheostomy in your setup? And how was the long-term prognosis?
I think it all depends on the neurological injury and the degree of incomplete neurological injury and Asia score. In a patient that, for example, would have jump facets bilaterally, and it will be an incomplete injury, or very mild incomplete injury like central core syndrome, for example, then I don't think that there will be a need for tracheostomy. However, if the patient has severe neurological injury, even if it's incomplete, then yes, especially if the patient has perioperative pneumonia or airway issues, then I think tracheostomy will be will be considered. Long-term prognosis, again, it depends on the degree of initial injury. I don't think it depends on the approach. I don't think it depends on if you do anterior, posterior, or 3 times. I think it depends on the initial injury.
Excuse me, do you mind if a panelist comments right now?
Please.
Yeah, let me introduce Ashish Tandon, a neurosurgeon from India who's done a fellowship with Charlie Teo in Australia. Good day, Ashish. Unmute yourself there, Ashish.
Hi, John.
Yeah, hi.
Great. Can you see me?
Yes,
And
we
hear
can
me
see you.
clearly?
I don't want to take him off the screen share. So go ahead.
Okay. So once again, thank you. And it's been a pleasure to join you and the team once again. So I would, for this case, for both the panelists and the speakers as well, for the rest, and especially for the youngsters, there's a huge difference as far as management of spinal cord, especially cervical cord injury is concerned in our parts and the West. So let me quickly tell you that after Michael Failing's paper on the timing for cervical spine injuries, where he said that, and it was a very popular paper, that the earlier you operate, the better is the result. But because of a lot of issues in our part of the world, especially for complete cord injuries or the type of injury which we are discussing right now, what our experience has been that first, because of social reasons, we don't try to jump for surgery early because the family does not understand what's going on. Secondly, they do not understand that a respiratory issue is the main problem, and management of respiratory issues is the where we are all involved. So we wait for 2 to 3 days, 4 days, let the patient settle. We also encourage the patient and the family to take second opinions, so that they are aware what we are talking about, and that's very important for us. Then as far as
cái hộp sữa mà em quậy
I'm sorry, let me get that.
chị hộp sữa nữa.
Okay, go ahead.
Trên á, bự màu xanh ở ngoài á. Không phải hộp sữa bự á, hộp sữa bự á. Hộp sữa bự màu xanh đó bự.
Okay, I'm sorry.
Yeah, so for me, again, early MRI and makes a huge difference as this type of, whenever I see this MRI where there is extensive cord injury, again, we are fairly slow in our approach. So we make no hurries, we give traction, we give time. Neurological status, again, is very important. Now, as you saw, I'm pretty sure that neurologically the patient has not improved because he has a C5, C6 injury. Some shoulder movement must have already been there, or maybe because of the spinal shock, he was not moving that. But eventually, till date, he has not had any neurological recovery. So again, the pressure is on the neurosurgeon, that why is he not improving? So the sum and substance of what I'm saying is just wait. Let the injury, the disease sink in. That's the first part. The second part that I would want to comment is about the reduction. And so there are 2 areas where in my practice, I find that reduction is much more difficult. The first is obviously C6-7 dislocation. Whenever you have that, it may not be that easy to reduce it. Also, many times if the patient is a little bulky, you may not be able to appreciate that whether the reduction is happening properly or not because of the shoulder. The second area where reduction may be difficult is when the patient is presenting to you, say after a few days or a week or so, though not similar to this case, but that is the second area where I find it difficult to reduce. So in such cases, and especially where I suspect that there's bilateral facet, I would go directly posterior and then try to reduce it and then move on anterior. The third thing that I would want to express is that whenever such a case comes, and especially post-operatively, we have a protocol of using BiPAP. So intermittent BiPAPs we use, because what is happening is the lung is not expanding. That is the first thing that is happening. And the second thing that is happening is because of the poor respiratory and diaphragmatic movement, the patient is not able to cough. So there is atelectasis, there is secretion, and then you have pneumonia. So one way to reduce the problem is by using intermittent BiPAP, where you can sort of expand it as you have correctly done, that try and go in for a tracheostomy as early as possible. So these were some of my comments as far as this case is concerned.
Yeah, thank you very much, Dr. Tandon. Highly appreciate your thoughts here. Yeah, as you said correctly, yeah, we have a different set of issues, preoperatively, postoperatively, intraoperatively as well. This part of the world, yeah, especially. The perception of the people, the attitudes, their concepts are different. So they are, most of the time, they're not very knowledgeable. Sometimes they're ignorant. So it's very difficult to convince them. So there are a lot of problems. Yeah. So we'll discuss with this as we go on. Anyway, thank you very much for your comment. Shall we proceed, John? Okay. So, yeah. This is case number 2. Again, under bifacet dislocation, young patient, army soldier, 32, road traffic accident, motorcycle accident, motorcycle collided with the lorry. And again, C56, Asia A, again, Asia A. So, same thing. So, I mean, similar location, 5-6. This is the MRI. Again, a considerable disc. I think you can appreciate it here well. So this is the disc there. But no significant chordedema compared to the previous patient, and no significant posterior ligament disruption. So I decided to go for close reduction. He came around 1 a.m. in the morning. So young patient, got a chance. So took a chance, did the close reduction, it was successful. And did the MRI showed the disc, so anterior approach first. But then the problems, so did the discectomy, and then we did not have, as I said, so we don't have this pedicle screw. So this actually provided by the patient. So what we do is, so we have the company, so we inform them, and then they bring these tools and the consumables, and the patient has to pay for that. But unfortunately, they did not have the correct sized peak cage for this patient. So I had to obtain a fibula graft for this. So this is the fibula graft. And then again, they did not have the appropriate sized anterior cervical plate. You can see this is not perfect. And also the screws, the length is dissimilar. So that's how it works in my center most of the time. And then, so patient was turned back and the posteriorly fixed C5-6 level only. So this is the post-op X-ray. So this is the CT. This is after the reduction, after the fixation. Yeah, only that area was decompressed. I usually decompress when there is edema at that level. And you can see the angulation of the screws were not perfect at that time, not as I wished, but I hope it serves the purpose. So this is the patient. Fortunately, that one, we did not want to go for any, we did not have any respiratory issues. This is post-op day 2. His neurology upper limb slightly improved, slightly, not so much. So still he's improving. Now we have sent him to the base hospital because we did not have HDU or ICU facilities to look after him. So that was that case. So do you have any comments on this, Sharon? So do you want to add some comment on this?
No, would you mind showing the post-operative X-ray? And you did close reduction, correct? And then you did
Yes.
anterior and posterior, correct? Okay.
Yeah.
Yeah. And this is a complete injury.
It's a complete injury. Yes, that's right.
2, 3, 4, 5, 6. Yeah, I think that's. I think I think it's a very adequate result biomechanically because you have complete reduction of the alignment. You have very good height restoration with fibular graft. The plate is not overlapping. It's not overlaying the other disc spaces. So
yeah,
I don't think it's inadequate per se. I think it's good.
Yeah, it's not perfect. Yeah.
But, yeah.
Okay. You'd have done the same thing, or you'd have approached it differently, or what you'd have done?
I would have tried to do a reduction, surgical reduction,
Right.
Open reduction,
Yeah.
either first posteriorly, but ultimately I probably would have done the same construct, posteriorly and anteriorly, one level.
Right.
Yeah.
Okay. So as Dr. Tandon, he correctly mentioned now, in my setup, so all these are young patients. So my policy is to operate as early as possible because there is nothing to lose. Patient comes with Asia A. So we know young people, they have a chance, they have a good chance to improve. So I take the chance and do it as early as possible rather than waiting, unlike in old age people. So that is my policy. Some people will not agree with me anyway. So that's how I feel. Right. So this is another case. 54 years, middle-aged, 30th of June. So this is his CT. This is C6, C7 bypassed dislocation. 2, 3, 4, 5, 6, 7. This was a bit difficult. So again, this one also I did. In this case, I could not. I did not have the opportunity to go for a close reduction. So straight away, we went for a open reduction. And at that time, we did not have MRI as well. So we just had the CT. So I had to straight away go for open reduction. And we approached him anteriorly, and I could reduce. And then posteriorly, because of the posterior ligament disruption and the highly instability, posteriorly also, patient was fixed from C7 to T1, including the junction. And 4-hour surgery. We sent the patient. It was a difficult one, as I said. C6, C7, as you all know, it's difficult technically. And I don't have, unfortunately, a post-operative X-ray or a reduction ACT or whatever because the patient died. That is because we did not have ICU at that time in June, because that is the time that the COVID had hit the country very badly. So we couldn't find an ICU, so we had to send the patient to the ward. And after sending, patient aspirated on day 2, and patient did respiratory arrest, and patient unfortunately died. So not uncommon in our setup. So especially during this COVID era, COVID times, and patient died. So unfortunately, I don't have anything to show you. So those are the 3 cases of bypassed dislocation I had during the last 3 months. So I would like to ask John if he has cases to share. So you can go ahead now. I'll hand over to you.
Well, let's see. I have Let me see if I can share something. I just want to show you briefly sort of the way I try to reduce these locations anteriorly, which is very similar to what I do, not to the extent, but similar to what I do for regular ACDFs. So this is a intro video, and you will see the video is faster, a faster speed. But what I do is I put the Casper pins, and at the same time I use my trial, whether it's 6 millimeter, initially 6 millimeters, and then 7 millimeters. But sometimes I use 5 millimeter trials, and ideally the wider footprint, either 40 millimeter wide or 16 millimeter wide. And then I try to, as I am placing leverage on the disc space, provided that the bone quality is adequate and there's no fractures, I distract the Casper pins. And I've seen significant advantage on getting into the disc space, restoring height, and actually getting back into the posterior osteophytes, the annulus. That allows me really to go all the way posteriorly and drill the posterior osteophytes and decompress the dura. So I tend to do all my SEFs with microscope. I know that some surgeons don't use microscope, but I feel like in my particular case, I can do a better job at performing central decompression and the foraminotomies as well. So I always perform at least a 14 millimeter wide or at least 14 millimeter wide central decompression, so that I can visualize the dura and look for retained fragments of discs. Now, I want to ask you, Sarath, what hemostatic agent do you use at your facility, or do you have available? Because there's some, in the US, we have some very expensive, sometimes very expensive hemostatic agents, without mentioning any names. But there's some ways around it. Like, for example, I used to use in residency the cheap gel foam powder mixed with either saline or thrombin. And then I would do that, and that would be my hemostatic agent. But what do you use in your facility?
Yeah, so we do have this, what is called Cervical. So that is what we use most of the times, and gel foam. But I don't like to use gel foam, especially in spine. Right. And Cervical is the one we use, and we have this what we call Tisil, which is very expensive, and it is very rare in my setup. So we have only 3 or 4 tubes, 5 millimeter, 2 milliliter or 4 milliliter. But nowadays we don't have that as well, so it becomes out of stock very quickly. So we don't have the luxury of using those hemostatic agents leisurely. So that's one of the problems. And to tell you the truth, I don't have a single curette for ACDF. So I'm doing ACDF without a curette. So I'm removing the disc with the drill, and then with the Kerisons and with the rangers. So it's sometimes it's a bit risky. So so I mean, that's how it goes. So I have done 3-level, 4-level ACDFs, maybe around 7, 8 without a single curette. So,
interesting.
So that's how the things are.
Yeah. So you so to remove the cartilaginous end plate of each end plate, do you use like a ring curette? Or
no, I don't have the curette. Yeah, that's why I said. So I use the diamond bell.
Okay. Yeah. I mean, you have to be very careful not to violate the end plate.
Exactly.
Of course. Yeah. Very careful. I see.
I think Harshad, excuse me, I think Harshad Parekh, a neurosurgeon from Mumbai, has a comment. Go ahead, Harshad.
Hi, John. How are you?
Good.
Welcome. Thank you. Sarath, nice cases. Few comments. As Ashish has already said, we also believe in that it should sink into the patient's mind. we have to remember one thing: when the neurological deficit is not likely to be reversed, and if we operate immediately and don't give a result, it becomes difficult to explain the patient's relatives and patient after that, especially in these younger patients. The second thing, what in my practice I am doing is I am putting a skull traction and pull that thing with a weight and try to reduce as much as possible and go anteriorly. And when I distract the vertebral body, most of the time the facetal dislocation reduces. And we fix with the plate and screw or cage and comes. I don't know why we are fixing posteriorly when we are able to reduce it, bring it in alignment. Anterior approach gives a good enough. We all know that these patients, they don't improve neurologically. And basically what we want them early rehabilitation. That is why this realignment and fixation is done. This is what my thought is there. Posteriorly, we only go when we can't reduce it from the anteriorly, or when the facets are locked in such a way. In that case, we have to go posteriorly. This is in my practice, this is what I'm following. And believe me, in majority of times, we are able to do it. This is just one comment which I would like to bring it to your notice. We do only one anterior. We don't do posterior. If I do the posterior, then don't come anterior. Because as you have said, patients are unstable. Why to subject them for 2 surgeries at a time? This is my comment. Thank you. Excellent.
Thank you very much. Thank you very much, Dr. Harsha. Thank you for the compliment and thank you for your comment as well. Right. So just one question, Juan. So Joanne, so how often do you do CT angiograms for the vertebral artery damage, potential vertebral artery injury in these cases? Do you do it routinely or do it in selective cases on?
I don't do it routinely. If it's for facet dislocation, yes. Yes, for facet dislocation, yes, I would do it routinely, except if it's below T1. But for facet dislocation, yes, I would. Yeah.
Great. So let's go for the next cases then. So I just have one case on cervical cord contusion. So let me share that one as well. So this is one case of cord contusion of the cervical spine, where a 60-year-old male presented with road traffic accident. Is a three-wheel driver, collided with the lorry, and on presentation, he had neurogenic shock and started on 9 probes. And this is at a time where we did not have the MRI scan. So this is what the CT scan showed us. So there was no significant dislocation, no fractures except this osteophyte fracture. So probably you're thinking about cord contusion there. So this patient, previously healthy patient, 60 years of age, and he improved a little bit within the next few hours. So his upper limb, the upper limb power was improving a little bit. So initially it was around 1 and then 2, but he was still in neurogenic shock. So I decided to go ahead with surgery. And so I approached him posteriorly and I wanted to do a decompression, but I showed extensive posterior ligamentous disruption and fracture of the posterior elements as well. So I had to do a long construct from C3 to C7. I did not have pedicle screws to insert the T1 level. So unfortunately, I had to stop, even though I did not want to do that. So I had to stop at C7. So this is what we did. So you can see his neck is very short. It's very difficult. So the junction, the C-arm was not showing anything. So I had to use the freehand technique. So very thick and short necked. So actually it's like no neck at all. And this is after 2 months, and he improved, significant, you can't say significant, but better than we thought actually. So that was just one case to tell you that without an MRI, so when you're treating these patients and they come with neurogenic shock, not stable to transfer, so I had to do this as well. I don't know whether you have done this before. So in your practice, I believe you have never encountered this type of thing, isn't it? Am I right?
Difficult. It's a difficult case. I'm sorry. So you went for, in the prior case, you went down to what level?
I went to C7.
Right. So you did all lateral mass, right? You didn't do
all
pedicle
lateral
screws.
mass. Yeah. I did not have pedicle screws. That's why I said I wanted to go all the way down, crossing the junction to T1, but unfortunately there was no screws, no pedicle screws, so I had to stop it.
Right.
So,
Okay.
Can I comment on this case?
Yeah, sure, of course.
Okay. So first of all, can you go on the pre-op CT? So on this CT, in a 60-year-old gentleman, I would have really thought twice prior to fixing it.
Mm-hmm.
So that's the comment number one. I would have, in a 60-year-old, generally, even if you have a OPLL, in fact, 60 years is the cutoff age, which literature says. Less than 60, you fix. More than 60, you can avoid fixation. In this patient, I'm not very sure, though you must have seen a flexion extension X-ray. And also, whatever scans I see, the posterior elements are not fractured, except I'm not very sure at C7, where the spinous process might have been fractured.
Yeah.
But
There were two.
I really avoided, perhaps. So that is comment number one. I would have just gone for a decompression. The other important comment that I have to make, that suppose even if you wanted to fix it, now can you show me your post-op? The SAG? Yeah. Now see, in this gentleman, even if you have decided that you want a fixation, say C3 to C6, C7, and if I agree, you have compromised the motion at even C1, C2 by just extending your rod up to C1, C2. So basically the facet movement there in a 60-year-old gentleman is being hampered. Even in your previous cases, the first or the second one, I don't remember, the rod is longer. So my suggestion to you would be to keep the rod much shorter. Take your time, assess the length, and even if you have to change, but do not compromise the facet movement. And especially in this patient where, C2-3 movement is important, why do you want to impact the facet joint there? So these are the two comments I wanted in this particular case.
Okay. Thank you very much. Yes. I agree with you. Actually, I had the same feeling before when I wanted to operate. I wanted to just do a decompression on this patient, 60 years. But then intraoperatively, I saw this ligamentous disruption, which was severe. So that's why I decided to go for a fixation.
I mean, there could be a difference of opinion. I don't disagree what you have done. Because, you could have fixation is fine. Again, even if fixation, then such a long segment, was it really required? Because you're compromising the neck movement in this patient who's already almost quadriplegic. So neck movement is very important in such patients. And even if you want to fix, you try to fix the least number of segments if possible. But I would not disagree with you if you say that, I want to fix. Okay, that's fine.
Okay. Thank you very much. Great. Right. Okay. Then, I just want to rush through this case because this is not so much. I just want Juan's opinion on this one. 44 years old, male, difficult in walking for 3 months. MRI showed a tumor at C71. So this is the tumor, C7, 2, 3, 4, 5, 6, 7, T1. Yeah. So he was investigated in a different hospital and he came to me for surgery. So probably a schwannoma with the MRI appearance. And so my question to you, so this is the MRI axials, which is only, this was the only available axial cut. So he had, so I know it's not very clear. So this is the tumor, mainly on the right side. Can see the calcifications as well, right? So my question to you, junctional tumor, C71. Most probably 2-level laminectomy. C71. Yeah. So would you consider? And sorry, I don't actually I don't have the flexion extension X-rays, but believe me, he had this loss of cervical lordosis and the degenerative changes as well. So I know it's only 2-level junction. So would you consider what is your opinion on this? You would go for a fixation or not, or just do a decompression?
That's a very good question, because I mean, it's very easy to say, okay, let's drop the screws fast. It takes 20 minutes. And then continue with the laminectomy and decompression. Really adding the instrumentation in this case would be quite easy, even freehanding. But the question is, does it really help the long-term outcome of this patient? I think my approach for this, if I'm going to resect an intracanalicular or intraspinal tumor or intrathecal tumor, it all depends on the amount of bone resection I will do. So if I do this case, it will be an open case. I will do a laminectomy. In this case, I think this tumor is eccentric to the right.
Yes.
I would like to do a generous laminectomy without doing facetectomies. But if I feel like I need to roll the tumor, if there's a plane between spinal cord and tumor, and if I need to roll the tumor away from the spinal cord to the right side, I probably will have to resect some of the medial facet, if not more than the medial, more than 50% of the facet on the right side, to roll the tumor away instead of trying to just move inside the spinal canal. So if I find myself resecting more facet unilaterally at the junction or going beyond the edges of the lamina, then yes, I may be forced to instrument, and that would be a decision, intraoperative decision. But I would try not to instrument, actually, in this case. If I can avoid it, I will try not to instrument. If this tumor is not solid, for example, and I'm able to resect it piecemeal and it comes easy, and I don't have to expand the laminectomy, then I'll try not to instrument. Especially if it's a young patient with good muscle mass, educated, that can actually follow commands, or use a brace for a short period of time, I'll try not to. But again, it depends on each patient.
Harshad, do you have a comment? Harshad, do you have a comment? I'm sorry to interrupt you, Doctor.
Yeah.
Go ahead. Go ahead.
Sarath, I wouldn't do the fixation in this patient. I'll try with the hemilaminectomy in this patient, and maybe we will be able to excise it without even excising any facets. And it will work very well and will not destabilize the spine. It is very one-sided tumor and will be easy to excise it. This is my opinion.
Right. So we had two opinions. So this is what I did. So this is post-op. I removed the tumor. I did the laminoplasty. So this is what I did. So this is post-op.
That's nice.
And this is him before the surgery on the day of operation. So he had difficulty on the right side. And this is how he walked. This is just before the surgery. And this is post-op, day 3.
Very good.
Yeah. So he came to me 1 week back, walking 90% improved. And yeah, post-op X-rays. I ordered the post-op X-rays, but he didn't come back to me. So probably I can show you in the next episode probably. So that's good.
Nice.
So,
Yeah, very nice.
right. Thank you very much. So I think we are moving to the last part of our the presentation. So this is a few cases on metastatic tumors. So Juan, do you have any cases to show us in the meantime?
Yeah, I have, you know, just to the going towards the issue of anterior posterior. Let me share with you something briefly. So I believe that the issue of anterior posterior is a huge question. What I tend to do both when I feel like the even if just the anterior column is compromised, if there is significant deformity and biomechanical forces, then I try to do both. Like this is, for example, a case of a lady on her mid-60s that had renal failure and comes with this MRI. So you see significant loss of the anterior column at 2 levels, 2, 3, 4, 5, and 6. With cord compression. Obviously, she was myelopathic. She was hyperreflexic. She couldn't walk very well. She was losing function in her hands for the last 3 weeks. And the only risk factor is hemodialysis in this case, diabetes and hemodialysis. No history of IV drug use, like most would try to find on the interview. And as I said, in these cases, just like in facet dislocations or deformity, I do CT angiograms. And it helps me because, you know, in this case, for example, because of the deformity, the carotid, the unilateral carotid goes very medial, very much in front of the deformity of the target. So that really allows me to plan my surgery in regards to dissection. And this is mobile. So this is sort of distracted and the MRI is more kyphotic. So that tells me that is working as a hinge. That's a relatively unstable segment. In this case, you know where you are, I can imagine you could use a fibular graft. Fortunately, this was a semi-mobile deformity. So with traction, intraoperative traction, you can definitely reduce this. I don't know if you have more neuromonitoring there. I tend to use neuromonitoring in this case.
Yeah.
Okay. So I tend to use that almost invariably on every cervical case that involves some sort of high restoration or correction or decompression of spinal cord. I've used Stagnaro test, so the wake-up test, a couple times when I have been in doubt of any significant change of motor bulk potentials. So in this case, it's a pretty standard approach. I have the luxury to use these spannable cages that I believe have significant advantage. And this is what the final result. So deformity correction and decompression. Patient was able to walk, obviously. No need for tracheostomy, thank God, although she was complicated with some pulmonary edema, which resolved. So I believe that when you find a case where, even if you do an adequate correction from the front, I believe that if there is a need for further decompression, if you're there, I think placing the screws it doesn't add to the case a lot more. There's another case I wanted to show you. For example, in this case, this is a gentleman in his mid-50s or late 50s with multi-level foraminal stenosis, multi-level central canal stenosis, and sort of like a stepwise ladder deformity. So in cases like this, where the million-dollar question is, what do? Do you go posterior? You go anterior? If you go posterior, you want to make sure you do adequate bilateral foraminotomies to be able to relieve the radicular symptoms. If you go anterior, you can do indirect decompression of the foramina. However, you want to make sure you do a good central decompression, right? So and then you're trying to pick either or, right? In this case, I thought that given that the patient was still ambulatory with some mild ataxia, loss of balance, definitely loss of grip strength and sensory function, I gave this patient the best chance, a relatively young patient for my patient population. So I gave this patient a chance to have both procedures. You can see, I think ACDFs, when they're done, when I use the technique that I used to use leverage on the disc space, I'm able to correct each disc space significantly. And even if you don't do complete reduction of listhesis, you do indirect decompression, whether it's with plates or no plates. You know, really the implant doesn't matter. I don't believe the implant, by the way, makes the surgery, right? I think the outcome is not made by the brand or the implant or the model. I think that the outcome is made by the surgeon. So I think that's my philosophy. So I think your cases are very interesting, by the way. I think you're doing the best you can with your resources. So again, hide restoration is very important in my practice. And in this case, the patient needed still posterior decompression as well. So yeah, patient's ambulatory bilateral hand function improved. So yeah, I think this is more like the extreme of my practice and elective practice, but the regular ACDFs, this is what I would do as well. Just a plain old, I try to really do indirect decompression and hide restoration, not by placing just a big graft on a small disc space, but by creating ligamentastasis and distracted the disc space adequately. This is another case where there you go. The same. I use fluoroscopy on ACDFs, obviously for the levels. From in the posterior cervical spine from C3 to C7, I do not use fluoroscopy. I do freehand technique with the Roy Camille technique. But for C2, yeah, 100% either fluoroscopy or navigation. Yeah. That's it. Go ahead.
Okay, great. Okay, so let's go on to the next few cases as well. So this is the two main areas that we are going to cover today: the bifacet dislocation and the metastatic tumors, cervical spine. So this is a 54 years old female presented with sudden onset bilateral lower limb weakness with a long-standing goiter. And the goiter was previously investigated. So I think you can see the goiter there. So this is the goiter. Oh, wow. See the large bladder, C5, C6. And MRI showed the C5, C6 metastatic deposit investigated by the medical team, bone destruction and cord compression. So bilateral lower limb power was 2 out of 5. And she had severe axial neck pain. And her SIN score was 13. So thyroid and the tumor. SIN score was 13, indicated that it's unstable. So this is the axials, large tumor. So I have a few questions before I go ahead with what I did in this case. So Joanne, so this patient was investigated for the thyroid nodule previously. It came as Thy2 on FNAC, and she was not investigated further. And she presented with sudden onset lower limb weakness. So in that case, I would like to ask you this question. Would you investigate thyroid further in this patient? Oh, what I did was I just did an ultrasound scan of the thyroid, and we already we had done a CT chest, abdomen, pelvis, and then I straight away went for the operation at the same time. So we had the general surgeon, the Association of the General Surgeon, and we did the total thyroidectomy at the same go, as well as the anterior approach to the cervical spine. So that was my approach. So what would have been your approach? What about the role of preoperative embolization, which is not available in my center? Can you tell me your opinion on this?
So this is a young, looks like a young patient, so definitely looks like a mass. Did you mention she had goiter before?
Yes, she had a
Okay.
long-standing goiter, which was investigated before, and the FNAC was done. It came as type 2. So it was benign initially.
Yeah.
But
Yeah.
yeah.
Mhm.
And then
Do
she
you have an
defaulted
ENT?
treatment.
Okay. Do you have an ENT surgeon there?
Yes, of course.
Okay,
Yes.
perfect. Yeah, I mean, yes, I would get medicine involved if he was here in my practice and do all the thyroid hormone panel, see what her current thyroid function is. Speak with a ENT surgeon. This will be a combined approach.
Yes.
With an ENT surgeon, where he will, do a thyroidectomy or partial or total. I'll leave it up to him. But then definitely to get to at least a pervertebral fascia, pervertebral space. I think the pervertebral space in this case will be compromised because it looks like it's infiltrated by tumor, which is infiltrating the vertebral bodies. So definitely CT angiogram. The CT angiogram can show you if the tumor is vascular to some degree. Not maybe as good as a digital suction angiogram. If you wanted to do, I know you don't have preoperative embolization here. Do you have preoperative angiography, like plain angiography capabilities at your facility?
Yes, we do have angiogram. Yeah, we did the angiogram for this patient as well.
Oh,
Yeah.
perfect. Yeah, that's what I would do. ENT, thyroid function, and CT angiogram. Yeah.
Right. So we did the same. We did the ultrasound scan. It showed features of suspicious features. So most probably it's from the thyroid. And we did, as we said, we did the ENT referrals and vocal cord functions checked, and the thyroid profile, endocrine team, endocrine team involved, and we did this with the general surgeon. So right, so it was unstable, and we decided to do the 360-degree fixation, but at a staged manner. So initially what we did the thyroidectomy. It took around 1.5 hours. And at the same time, we did the corpectomy, C5, C6. And we did and we inserted the expandable cage. So this is how it looked like.
Very nice.
This is the cage. And right, so, and then since it was unstable because the pedicle of the right side that was involved by the tumor, so I decided to go posterior as well. So this was after the posterior fusion. It was done 1 week back, 1 or 2 weeks back, as far as I remember. Lateral mass fixation was done. This is the video.
Okay.
Ashish, do you have a comment?
I don't have a CT film because they were out of this CT film, so we just had to go and get the video through the console. So, right.
That's fine. Did you find any preoperative compromise of the vertebral arteries in this case?
No.
Okay.
No.
Yeah, I bet that the tumor was invading or was encircling the birds on either side. So in this case, you have to be very careful.
Yes,
that staying right at the midline. You know, even if you leave tumor around the bird, that can be treated. I'm not sure how, radiation, etc. But you have to stay in the middle. I would use an AP X-ray at least, just to make sure.
Exactly. Yeah. Right.
Very nice.
Okay. So you'd have done both the anterior and posterior fixation.
Let me see one more time the sagittal MRI. If you don't mind. Yeah. So I think so. There is a couple of problems, right? Cord compression. There's destruction of the anterior column. Maybe the middle part of the middle column.
Yeah, the pedicle.
There's no destruction of the right side. Right. There's no destruction of the posterior column. How old is the patient?
50. Yeah. Let me see. 53. Yeah. 54.
Okay. Non-smoker, right?
Yeah, non-smoker, female.
Okay. I would have. I think I would would prefer not to do a posterior approach, given, I mean, pending the pathology, pending the prognosis, looking at the overall state of the patient. I mean, we treat the patient, right? So seems like this patient has already a significant compression fracture in the, I think is the thoracolumbar junction.
Yeah, fracture.
Severe goiter. So I would try to do anterior approach and wait. If the patient has good neurological results and stable, I would wait, because I would wait for pathology, prognosis, and overall hemodynamic state. So that's what I'll do. And then if the patient is healthy enough, if there's other risk factors for kyphosis or hardware failure, smoking, osteoporosis, steroid use, for example, then maybe I would prefer to do to supplement with a posterior tension band.
Yeah, great. Yeah. So once the anterior resection was done, after 2-3 days, she was improving. The lower limb function was improving. So she had a very good, I mean, very quick signs of. She showed very quick signs of recovery. So that's one reason I decided to go posteriorly, and then we sent her for the radiotherapy and the adjuvant treatment to the oncologist, and it confirmed as a thyroid metastatic deposit, and it was papillary, which is a rare occurrence, and she's still recovering. But compared to the preoperative stage, I think she has recovered significantly. Unfortunately, I don't have a picture or a video of her, so I will try to show you if she comes to the clinic. The problem with these people is that we lose them in the clinics. So even though how much we convince them, so it's very difficult to keep them under the continuous follow-up. So most of the patients we lose at follow-up, so which is beyond our control. Right.
Yeah, that's interesting.
Yeah. Do you have any cases on metastatic cervical spine tumors?
At this time, those are probably old films, but let me see now. I mean, the last case that actually was inconclusive was this one, the one that I already showed you. But I believe that so what you're showing is not only a problem of compression, but biomechanical instability, just like in your case. So I believe that if the anterior column is impaired, then you need to fix that. Especially if the culprit for cord compression is anterior, just like looking at a degen case. And yes, if the patient has good Karnofsky and good overall prognosis, and maybe having risks for failure for kyphosis, then yes, a posterior approach will be ideal. Like in this case, for example. So it's interesting. I think your cases are very interesting, and you're doing a great job. Even with the limitations that you have. I do have. I can appreciate the situation because I did medical school in Peru, and it's also considered a third world country, and you don't have the availability of tests and a lot of things like you're showing. I'd really appreciate that. Interesting how we practice medicine and neurosurgery differently in different parts of the world, but still we look for the same outcome. It's very, very particular. I'm really excited to continue these conversations and case discussions in the future.
Thank you very much. So it's going to be the last case. Right. Okay. So so this is quick, a very quick opinion from you, because this case, and I would like to get the opinion from the panelists as well, because I had a lot of doubts regarding this patient. 68 years of age, male, history of adenocarcinoma of the salivary glands, submandibular, undergone surgery and neck dissection plus radiotherapy locally, and presented with a sudden onset of bilateral lower limb weakness. This is to my colleague in a different hospital, and the MRI showed T1 cord compression. So I'm sorry about the the quality of the imaging, because I don't have the images because the patient went before I gathered the images. So this is the cord compression is at T1. There was significant cord compression both anteriorly, mainly anteriorly, and he presented mainly with axial pain and the local pain. His main complaint was local pain after coming to me. So this patient underwent and had undergone posterior decompression with laminectomy and fixation from C7 to T2 done by my colleague in a different center. And he presented to me with a wound dehiscence at the posterior exposure wound. So what I did, I repaired the posterior wound, and then I kept him in my ward. His initial, when he presented to me, his power, the lower limb power on the right side was 0, and on the left side was just flicker of contraction. And he complained continuously of local pain and axial pain, which I thought coming from this anteriorly placed the deposit, because he had only undergone the posterior decompression. That is because of the problems with the access at the level of T1. So, actually, I have few experiences in doing T1 corpectomy, and I know in my setup we don't have a cardiothoracic surgeon for a sternotomy, and so we don't have double lumen. So I know it's a difficult procedure, but and also this patient had undergone surgery in the oral cavity, so we had to intubate him through the nose, nasal intubation, awake intubation. So many difficulties we had, and this is how he presented with. This is the CT scan. So you can see the posterior fixation was done from C7 to T2. C7 to T2. So I had plans of doing a T1 corpectomy in this patient. So I did the T1 corpectomy, and I was planning to do a fusion with expandable cage. It was a highly vascular tumor as expected. The corpectomy was done. And unfortunately, the C-arm was not actually a very good quality C-arm we had. It stopped functioning in the middle.
That's
right.
nice.
Yes, stopped functioning. So I did the corpectomy. So you can see I did the corpectomy at T1 level 2, 3, 4, 5, 6, 7, 1. But I could not insert I could not put the cage in. So I had.
Was that an anterior approach, Surath?
That's the anterior approach. Anterior approach without splitting the sternum.
Very good.
Right.
Very
but
good.
unfortunately, yeah. So this happened, and then I postponed the surgery because I knew I could not. Even though I had the exposure down to T2, I had difficulty in inserting the screws without the C-arm. So I planned it in few weeks, because it's already fixed posteriorly. His local pain subsided immediately, and he had no dysphagia or hoarseness. But in the meantime, unfortunately, he developed a fever, and his blood culture became positive. So I had to postpone the fixation anteriorly to few weeks until he responded to antibiotics. So in the meantime, his histologic MS, poorly differentiated carcinoma favoring metastatic deposit of adenoid cystic carcinoma from the salivary glands. So it was a poorly differentiated carcinoma. So I had second thoughts before fixing him, considering his situation. After the procedure, after the anterior resection procedure, his left upper lower limb power improved to 3 out of 5. And right upper limb power improved to 1 out of 5. But unfortunately, the patient's next of kin, she was not very happy about the management, although we kept him all the way 1 month and we treated him. So the next of kin was, she was not very happy about the management and say, this is what happens actually, how much we convince them. And she was getting second opinions from some others. So, I mean, she was not happy. So I had to refer the patient to the oncologist, and I gave them the option of and I asked them to, so you have the whatever the freedom to go to a different session, and you can get the second opinion. So before I insert the cases, so they went. So they went to a different center. I don't know, maybe to the oncologist. So even though we refer to the oncologist, they wanted to go to a different oncologist. So these type of things happen, in my setup. So my question was, so do you have experience in T1 corpectomies?
Yes, but honestly, I have not performed a sternotomy. If I had to, I would definitely use a thoracic surgeon's assistance. That approach seems pretty, it's pretty technical, because you're on top of the great vessels. You have to be careful with the thoracic duct. I think on T1 corpectomy, the majority are not the easiest approach. Yeah. And in order to not, in my case, not to run into difficulties with angles and placing the hardware, I would try, if I'm forced to do a T1 corpectomy, I will try to do a lateral extracavitary approach, because you can protecting the dura and resecting the part of the rib up to 7 centimeters or 8 centimeters of the rib. When laterally, you can get really ventral, and you can really decompress the ventral thecal sac and place a cage as well. I mean, I've done that all throughout the thoracic spine, ideally from the right side, to avoid adancoids at the right levels. But yes, that would be my, if I had to do this, I will try to do that. I will try to do a lateral extracavitary approach. Now, in the case you mentioned, the patient apparently already had a posterior surgery, so it's more difficult to do a second posterior approach.
Yeah. Okay. So I think that's it from my end. So do you have any other cases to show? So that's I think that's it for today. So I thought of discussing OPLL and the degenerative on a different day, on a different chapter.
Yeah. Perfect.
Okay, great. There was a lot of I'm not a neurosurgeon, but I appreciate good education and interaction. And I thank you, gentlemen, for taking the time. And thanks for Ashish and Harshad to come in. And hope we'll talk about what we want. I'd like to do this in a couple of weeks, but we'll talk about that. And we'll see where we're going to go forward. So, okay, I'm just going to end this broadcast and stick around for a sec. Thank you very much.